in the Centera system and really do some great things. So let's see if I can actually get this to work. So to kick things off, just a little bit of background. I'm sure everyone here is very familiar with the burden of chest pain in the ED. This is the second most common symptom that's evaluated by ED physicians, second only to abdominal pain. And there's approximately 8 million visits of chest pain visits to the ED annually throughout the US. So it's quite a lot. However, only a small minority of these patients who come in with chest pain actually end up having a heart attack or an acute coronary syndrome. And that's really what the ED physicians are challenged with, taking this huge mass of patients who come into busy EDs and identifying the ones who are high risk, the ones who are at risk of having a heart attack or something severe that really warrants urgent management. And so our current strategy for triaging these patients in the ED has some limitations. And because of these limitations, it's very common for patients to come in and stay in the hospital in observation bays for long periods of time. They often have to wait for insensitive and expensive stress tests, usually, as long as the next day, 24 hours plus. And many of those stress tests, as you know, are often normal. And so this leads to little change in management or outcomes, and consequently high costs for the hospital system, a number of patients being unnecessarily admitted, and ED overcrowding, which we know is becoming a serious problem throughout the US. So I wanted to just kind of walk through what is the usual care pathway when someone comes in to the emergency department with chest pain. So we have a patient arriving at the ED. Typically, they'll undergo some sort of initial triage, H&P, often by a mid-level provider or a nurse. That patient then gets a baseline EKG to assess the electrical activity of the heart, some labs, including the troponin and cardiac enzymes. Usually they're observed for a period of time. They get serial EKGs, so a follow-up EKG, follow-up troponin level. And then they're often observed in either a telemetry bed or some sort of a observation bay within the ED. Then, they undergo a stress test frequently the next day. At that point, depending upon the results of the stress test, the physician may decide to order another diagnostic test, such as a PE protocol, CT, maybe an aorta CT, and other testing. Hopefully by then, they'll arrive at a final disposition, and that patient will either be discharged home or admitted for further care. So that whole process can take upwards of 24 to 32 hours. It's a very cumbersome, time-intensive, resource-intensive process. And obviously, patients are not satisfied having to stay in the hospital system for this workup for 24 to 32 hours. So what we propose, and what's been validated in a number of clinical trials, is a CT first pathway, where we shave off a considerable amount of time and testing to arrive at our final disposition much faster using cardiac CT. So the patient will arrive, they'll undergo their initial triage, get some baseline labs, and then based upon their pre-test assessment, the ED physician will order a cardiac CT. The patient will undergo that exam, and a final disposition can be rendered, usually within 3.5 hours. So I mentioned there's a number of trials now that have been performed, throughout the last decade. I'm not going to go into the details, but just to show that these are randomized controlled trials, high quality trials that enrolled thousands of people. And collectively, the results of these trials show that if you have a CT first strategy to triage chest pain in the ED, it leads to a faster time to diagnosis, shorter ED length of stay, fewer hospital admissions, lower costs for your hospital system, less downstream testing, lower MACE, which just stands for major adverse cardiovascular events. So it's a very safe test, and it affords greater diagnostic confidence and greater patient satisfaction. I mean, patients just really don't want to wait in hospital beds for 24 to 32 hours. So it's important to note that this test is not for everyone. It's really most effective in patients who come into the ED and they have a low or intermediate pre-test likelihood of acute coronary syndrome. So it's not the patients who come in with crushing exertional chest pain. They get an EKG and they're showing that they're having an active heart attack, a STEMI. Those are patients that obviously are going to go straight to the cath lab, be seen emergently by a cardiologist. Who we're talking about are patients who come in, you know, their signs and symptoms are somewhat suggestive of an acute coronary syndrome, but it's not entirely clear what's going on with these patients. And so the ED physicians have pre-test risk assessment algorithms to determine if a patient is low risk, intermediate risk, or high risk just from the get-go. And it's really those low and intermediate risk patients that should be funneled for the CT first pathway. We also have data from this trial called the CATCH trial, which looks at long-term clinical outcomes of patients who are triaged with a CT first in the ED. And so what this study is actually a very important study, because what it shows is that if you follow these patients for 2 years after their ED visit, and you look at the ones that underwent cardiac CT or coronary CT here versus those who didn't, who underwent that traditional pathway that involves stress testing, you get this very nice bifurcation of outcomes. And so, you know, on the top here, we see coronary CTA, and the bottom, we see the usual care pathway or stress testing. And this is event-free survival. And so the patients who underwent cardiac CT had lower adverse events than the patients who underwent the usual care pathway. And so, you know, just showing that, you know, this is actually, you know, having patients undergoing cardiac CT improves outcomes. It's not just let's get them through the ED faster. We're actually seeing less myocardial infarctions, fewer rehospitalizations, and that's really important when we think about who we're caring for. Along the same lines, we have this big trial that was conducted in the UK, the Scott Hart trial that was published in the New England Journal, that looked at the 5-year incidence of myocardial infarction after cardiac CT. Now, granted, this study actually looked at patients with stable chest pain rather than acute chest pain, but I think the data is really important. We see a very similar bifurcation in outcomes when we compare patients who underwent cardiac CT versus the standard care. And what this is showing is the incidence of myocardial infarction. So it's very clear that if you follow up these patients 5 years after their non-invasive test, the cardiac CT patients fare much better. So much lower incidence of myocardial infarction. I think, you know, what really makes cardiac CT such a great study is that it has this perfect triad. It has very high accuracy, which has been demonstrated in a number of trials. So it's very good at identifying obstructive disease. It very rarely misses not a very severe obstructive disease. And so in addition to a high accuracy, it's very safe. Patients who go through this study, they fare very well. We're able to improve outcomes and lower the incidence of myocardial infarction. And on top of that, it's cost effective. And so compared to stress testing and this usual care pathway, we're able to save hospital systems like Sentara lots of money, which is important. And so increasingly more so as we get into different types of reimbursement models like value-based reimbursement. And so that's going to become increasingly more important over the next decade as we kind of transition from fee-for-service into value-based care. Another thing worth mentioning about cardiac CT is that unlike other triage tests, it offers a warranty period. What do I mean by that? Well, you come in and you get a cardiac CT and it's negative. We can safely and confidently tell that patient that you are not going to have a heart attack in the next 5 years. Your disease is not due to obstructive coronary artery disease, and so your 5-year warranty is very safe. And so this has been kind of demonstrated in a number of trials now. And what's nice is that, you know, if a patient comes in with chest pain to the ED, they want to know what's causing that chest pain. And it's very difficult to tell them that you don't have coronary disease if they go through that usual care pathway. So with cardiac CT, we have an anatomic screenshot picture of the coronary arteries. We can actually safely and confidently tell patients that you are free of coronary disease, and your 5-year warranty looks very good. So that's a unique feature of cardiac CT. Now we're seeing adoption of an endorsement of cardiac CT by a number of societies, the American College of Radiology, the American College of Cardiology, and so unlike what we had 10 years ago, we now have a very strong endorsement from a number of societies that are jumping on board and supporting cardiac CT. So who's appropriate for the CT first pathway? We mentioned patients have to have acute chest pain, low to intermediate pretest probability for acute coronary syndrome. And really that means, no evidence of, real severe ischemia on EKG, a negative or equivocal troponins. At Sentara and Norfolk General, they're transitioning to this high sensitivity troponin, which is great. I mean, that actually is going to identify patients who have myocardial necrosis at a much more sensitive level. And so even some of those patients with equivocal high sensitivity troponins are going to be ideal candidates for cardiac CT. Who's not appropriate for cardiac CT? So what are some of the absolute contraindications? Really, patients who have severe renal insufficiency, unless they're on chronic hemodialysis and cleared by a nephrologist, really those are not ideal candidates. We're giving IV contrast, and so it's important to be mindful of the damage that can do to the kidneys. If a patient comes in with a severe iodine contrast allergy, even with pre-medication, severe contrast allergies, we should pause and probably route them through a different triage strategy. And then uncooperative patients. I'm sure everyone here who's on the call right now has had that uncooperative patient. This is really bad news for cardiac CT, because uncooperative patients, we need them to hold their breath for several seconds and lay still. And if anything's going to kill image quality with cardiac CT, it's motion. So it's an absolute contraindication. If you have a patient who's thrashing around and is not being cooperative, that's an opportunity to stop the exam before we inject and let the ED physician know. There's also some relative contraindications, mild to moderate renal insufficiency. So an estimated GFR, between 30 and 60, is usually we need to at least have a discussion with a physician and make sure that we're taking all the proper precautions to prevent further renal injury. And then pregnant patients. So, there's some data now that we can, depending upon the pretest risk, scanning pregnant patients may be okay, but I think we need to follow our institutional policies on injecting IV contrast in pregnant patients. So, what are the requirements to generate high quality images for us? Obviously, having the right type of CT scanner is important. So it needs to be capable of synchronizing the image acquisition to the ECG. So having a high temporal resolution is very important. Basically, that's like your shutter speed for the CT scanner, and having at least 64 detector arrays, and all of the sites that we're scanning now meet this criteria. Slow, steady heart rate, very, very important. So we have a very aggressive pre-medication protocol that I'm going to go through here in just a moment. And having that steady heart rate is really important, because the slower and more regular the heart rate, the higher the likelihood we'll be able to generate motion-free images of the coronary arteries. We also want the coronary arteries to be nice and plump if we can, and so we dilate them with nitroglycerin. And that's being done in a number of different ways, but typically, sublingual nitroglycerin when the patient's on the scanner table just a few minutes before injection. But it can also be done topically with this nitro paste. And that's a protocol I think we may migrate to for these patients coming from the EDs. The ED nurse will just slap some of this nitro paste on the patient. They'll get wheeled over to the CT scanner. And then instead of having to give another medication on the scanner table, that patient will all be ready to go. And then when they get back to the ED, the nurse can just take that topical, the nitro paste off. High flow IV is also important. So injection at 5 to 8 cc's per second. And that's going to require at least a 20 gauge IV, preferably an 18 gauge in the antecubital or more proximal. So, we never inject, at this rate in the hand or the forearm. It's just, it's too risky. If there's an extravasation, that can cause, a very serious compartment syndrome. And so injecting at the, making sure that IVs in the antecubital vein or more proximal towards the heart is also very important. And breath hold. So I mentioned uncooperative patients, absolute contraindication, because we have to be able to have this patient hold their breath for the duration of the scan. And all of you know, I mean, our goal with all CT imaging is to obtain the highest quality images at the lowest possible radiation dose. So following this fundamental principle of ALARA holds true for what we're doing. Now, one of the protocols that we're going to have patients routed through out of the ED is what's called a triple rule out pathway, or a multiple rule out is what we call it on our poster. And this is just the modification of the cardiac CT to also exclude pulmonary embolism and aortic dissection. So we can exclude coronary disease, PE, and dissection within a single imaging session just by modifying that cardiac CT protocol a little bit. And so what do we modify? Well, if you take your scout, your frontal scout, typically with a cardiac CT, we start scanning at the carina down through the base of the heart. With triple rule out, all we do is really extend that field of view cranially from about the level of the clavicles just above. We don't even have to include the apices. But we extend the field of view, several centimeters, towards the top of the clavicles. And so, usually there's about a 30% greater scan coverage than conventional CTA. And so consequently, the breath hold time is going to be a little bit longer. And because we're trying to opacify vessels, the coronary arteries and the aorta, as well as the pulmonary arteries, we're going to have to give more contrast so that we can get all of those vascular beds to light up at the same time. So usually we give about 30 to 50% more IV contrast with the triple rule out protocol. There's some pros and cons of triple rule out. Pros, there's data now that there is a similar diagnostic yield for obstructive coronary disease. So we can still safely and confidently exclude severe coronary stenosis. And there is a reduction in the need for additional testing in most patients. So what do I mean by that? Well, if we do a triple rule out, we're not going to need to do a follow-up PE protocol the next day or a follow-up CTA of the aorta the next day. We're going to have all that information in one imaging session. So that is a benefit. And there's a higher yield for detecting PE and aortic dissection, obviously, having that single protocol. But I mentioned already, with this protocol, the radiation dose is going to be higher because we're scanning more of the chest. We're going to be giving more IV contrast, so there's a greater risk for a kidney insult. It's marginal, but it's real. And then there's also data that it's a little bit harder to generate very high quality images of the coronaries. It can be done, and a lot of that just really depends upon the experience at each site. But there's a slightly higher risk of having an uninterpretable or poor quality study of the coronary arteries. And so that's just something to be mindful of. This is not a pathway that we advocate for everyone, but only in select patients. And I'll go through which patients here in just a moment. So here we go. So what's the algorithm for triple rule out? We actually condensed this figure down in our poster that's going to be up in the EDs. But really, if you look at patients who come in, with acute chest pain, if they're high risk for PE or or aortic dissection, they're going to be undergoing dedicated pathways for PE and aortic dissection. So dedicated PE protocol CT. If they're high risk for coronary disease and they have signs of ischemia and elevated troponins at baseline, they're going to go to the cath lab, right? So we're talking about, again, these low to intermediate risk patients. If they have intermediate clinical suspicion for PE, i.e., a history of DVT, malignancy, immobility, then those are patients we should be considering for the triple rule out. Similarly, if they have an intermediate suspicion for aortic dissection, such as a history of Marfan syndrome, one of the collagen vascular diseases that predisposes patients, makes them higher risk for aortic dissection. If they have an aortic aneurysm, a recent surgery, or classic, clinical signs of and symptoms of aortic dissection, like this ripping, stabbing, tearing pain, then those are also patients we should consider for the triple rule out. Otherwise, if they're low to intermediate risk and don't have any of those suspicions, we should just be doing a dedicated coronary CTA. So this is part of the poster that we're going to be posting throughout the EDs and also in the CT suite, so you guys have access to what's going on in our algorithm. We're selecting patients who are low to intermediate risk based on initial presentation, baseline EKGs, and baseline troponins. And if they have signs and symptoms suspicious for either PE or acute aortic syndrome, aortic dissection, then we'll have that patient undergo a multiple rule out or a triple rule out CTA. Otherwise, they'll undergo coronary CTA. And so this is a reminder that, when we select these patients, we want to aggressively pre-medicate them so that we can try to get that target heart rate, as close to 60 or less than 60 beats per minute as possible. So slow, steady heart rate is really the goal for these patients. We'll acquire the CT exam after or around the same time of the CT study. They'll order a second set of troponins and EKG, and then we'll have our disposition in about 3.5 hours or less. So again, this is part of the poster. We talked about IV access. 18 gauge is really preferred. 20 gauge we can inject at 5 cc's per second, but it's less preferred. So making sure that the ED is putting in these 18 gauge IVs is really important so that we can generate those high quality images. This in white here, we kind of go through our pre-medication protocol. And so again, the goal here is just to achieve a steady heart rate less than 60 beats per minute. The first line medication that we give for heart rate control is metoprolol. And so we'll titrate oral metoprolol in the ED initial dose based on what the baseline heart rate is. So if the heart rate is 70 to 80 beats per minute, we're going to be giving between 100 and 150 milligrams of PO, oral metoprolol. And we can redose after 30 minutes if needed, all right? And there's contraindications to metoprolol. Metoprolol is a beta blocker, and so if the patient has any allergy to beta blockers, they won't get this. If they have heart block, then second or third degree heart block, they won't get the metoprolol. And then severe asthma with active wheezing is also a contraindication. And hypotension, so systolic blood pressure less than 90. We're going to hold on the metoprolol. Our second line is IV metoprolol, and this can be given either in the ED right before the patients are transported over, or on the CT scanner once the patient's all prepped on the scanner table. And typically we give these in 5 milligram increments via slow push, and we can redose every 3 to 5 minutes up to 40 milligrams total. So this is a little bit of a time-intensive process, giving these small increments of metoprolol on the scanner table. It kind of eats up scanner time. So we try to really be aggressive with the oral metoprolol because we can give much greater doses and it doesn't tie up a scanner for a long period of time. Same contraindications for the IV. Our third line medication is oral Valium. And so I find this very helpful for patients, especially those who are coming in with cocaine abuse, who, you know, there are, for whom there are some risks of giving metoprolol and beta blockers. But it's basically an anxiolytic. And we can give 5 milligrams PO for heart rates greater than 60. Because it's an anxiolytic, there's some different contraindications. This is a different class than the beta blockers. So if there's a known allergy to the benzos, severe hepatic insufficiency would be a contraindication. And we wouldn't want to give this medication to patients who come in on their own to the ED and don't have a ride home, because it will make them somewhat altered. And fourth line is calcium channel blockers. So IV diltiazem. So we give 5 milligrams in the ED over 2 minutes, and we can redose that every 10 minutes. So diltiazem is a calcium channel blocker, and that, again, a different class of medication. So we have a number of different medications in our arsenal. Our go-to is really the oral metoprolol. We want to be as aggressive with that as we can and get the patients to that target heart rate while they're in the ED. So when they come over to the scanner table, they're ready to go. We scan them, get those high quality images, and get them back to the ED for that disposition. Nitroglycerin is the other medication I mentioned for vasodilation. So we'll either be giving 2 sublingual sprays 3 minutes prior to injection on the scanner table, or we can give a 1/2 inch to 1 inch of nitro paste while the patient's in the ED. And that would obviate the need to give additional medications in the scanner suite. There are also contraindications with nitroglycerin. So hypotension, this medication can cause hypotension. So if the systolic blood pressure is less than 90, then the nurse will hold nitroglycerin. Another important contraindication is the use of the phosphodiesterase 5 inhibitors. So the erectile dysfunction medications like Viagra, Levitra, Cialis. If patients have used those medications recently, then we definitely want to hold the nitroglycerin, because that can cause a unsafe drop in blood pressure, which you hear on the commercials. And so those are patients who definitely should not be getting the vasodilation. Severe aortic stenosis or hypertrophic obstructive cardiomyopathy, any sort of outflow obstruction is also a contraindication to nitroglycerin. So a reminder, this is also from the poster. When do you call the radiologist, the imager, or the cardiologist on our team? Really, if the heart rate remains above 70 and we've given all these medications, then it's time to make a decision. Do we want to attempt to scan this patient, or should we have this patient undergo different testing? Any history of congenital heart disease. If this is a patient with atypical anatomy, then the imager should know prior to scanning, so that we may we may want to modify how we scan these patients to make sure that we're going to generate good quality images. Anyone who has a pacemaker, the imager should know about it. Similarly, iodine contrast allergy and any renal insufficiency cases with a GFR less than 45. So in summary, CT first can improve patient outcomes, lower costs, and decompress EDs. We want to, we want to actually leverage this pathway to help take care of our patients the best we can, and make the pathway as efficient as we possibly can. The CT protocol should be tailored to the patient heart rate, size, and scanner type to maximize image quality with the lowest possible radiation. And triple rule out offers a one-stop shop protocol to exclude coronary disease, PE, and aortic dissection, but at the expense of greater radiation and contrast and lower image quality. So thank you all for your attention. I really wanted to, create a conversation around this and answer questions and make sure everyone's sort of, on the same page. I didn't want to just lecture for the full time. So I think at this point, what I'll do is take any questions you guys have. I'll stop sharing my screen, and Mo and I can try to answer whatever questions you may have at your hospitals, and you know, how we can you know, best work together to roll out this pathway.
So I have two questions. With the ED drugs, you said they should not have had them recently. Can you give more of a time?
Yeah, that's a good question. So I think with Levitra and Viagra, the rule is 24 hours. With Cialis, we extended up to 72 hours because it has a longer half-life.
Okay. And then as far as the contrast allergy, do you have any recommendations for the pre-medication for that?
Yeah, it really, so there is an ACR recommended protocol, and I think most hospitals will have a, you all probably have a pre-medication pathway
Right.
or protocol for patients. And we, you know, ours is no different. Usually it's like you get, it's a 15, 7, and 1 hour protocol. And I have to go back and look, but I know you.
Right. So then if they're in the ER, then they would have to wait for 15 hours, basically. Is that correct?
Yeah.
To get there? Okay.
Yeah. Now, sometimes in the ED, you can do the expedited 4-hour pre-medication protocol, but you know, I would only advocate that pathway, the expedited pre-medication protocol for patients with very mild allergy. If they have any sort of moderate allergy, you know, if they have any, certainly any anaphylaxis or anything severe, you know, we would not recommend pre-medication.
So you mentioned reducing radiation dose, and we have the harder patients over here, so we tend to do mostly retrospective, 20 to 80 in the phases. Is there a better way to do these ER patients to reduce the dose?
Yeah, that's a great question. And absolutely. So I think one thing that we want to do is really optimize protocols. If you have a cooperative patient come in and we're able to establish good heart rate control and get that heart rate down, you know, 60 or less, then we definitely want to advocate for prospective triggering. And so we will tweak the protocols with you guys, with your help, and really push for prospective triggering, you know, usually with a pad between 60 and 80% of the R to R interval for those patients, because that'll substantially reduce radiation exposure. And if you have a cooperative patient and we have good aggressive heart rate control, there's absolutely no reason why we shouldn't do that. So now if you have the patient who is in a little bit of an arrhythmia, maybe a little bit of, they're having paroxysmal atrial fibrillation, you know, then for sure we want to do retrospective gating, because we want to optimize the likelihood for you know, high quality images. But Randy's point's well taken, and part of this part of our protocol will be, you know, helping you guys identify which type of scan you want to do for each patient. So based on the heart rate, you know, should you do prospective triggering or retrospective triggering? Ultimately, it will be your decision. But with the prospective triggering, we have a smaller window in the cardiac cycle to capture images. So our margin of error is much lower, you know, but the radiation exposure is going to be also much lower. And so there's a trade-off between, you know, how much data you want to obtain and how much radiation you want to, you know, give to the patient. So we want to tailor that. If we have patients coming in with low heart rates who are cooperative, then we should be, our go-to protocol should be prospective trigger.
Now, on that prospective triggering, though, especially with the triple rule outs, if their heart rate is very low, you run into the problem of the scan being too long for the dose. So my suggestion would be maybe retrospective gate, but just narrow your percentage of a window.
No, that's a great point. So Kim, yeah, that's a great point. We can actually, So we'll work with you on customizing those protocols, and it's going to vary by scanner. But you can take a retrospectively gated exam, and you can do what's called tube current modulation and really drive down the dose, the radiation exposure during parts of the cardiac cycle where you're not going to obtain useful information, such as during systole. And the net effect from that can be also a much lower radiation exposure exam. So that's a good point. And we'll work with you on customizing those protocols at each site so that we have some good options.
I have a question. Sorry.
Just curious, are we recording this session? Because I forgot to invite the RNs at the heart hospital.
Oh, shame on you.
I got left out.
It's being recorded, and this apology is also being recorded.
That's okay. We have 2 other techs too that are coming in later, so that'll be good. They're aware.
I'm from the corner. I have a question regarding AFib because I've always understood it to be a relative contraindication to cardiac gated imaging. And so it seems as though you're saying that it may not be quite the killjoy that we really kind of felt like it was. So can you speak to how badly it degrades image quality? Are you still getting a diagnostic quality test that you can sort of almost still rule out coronary disease? Or is this a patient that we should still be turning away for the most part?
So I should take that one, because for 15 years I have taught our technologists that if somebody's in AFib, just stop the test and don't do it. But I have been recently educated by our director of CT strategy. You'll meet next month. Elvis Camus is just one of the smartest guys I've ever met, and he has shown me a new way of scanning people in an AFib, and you get good quality studies. It's a little bit harder to read, and that's why I was hesitant for a long time to do it, but it can be done. You either scan people retrospectively with a lot of phases in the cardiac cycle, and then you then reconstruct with R wave plus 300 milliseconds. Mm-hmm. And it turns out it's a little bit harder for me to read, but it's diagnostic for the patient. So we are definitely moving away from what I used to think, which was that we should just send people away from AFib. And the truth is, we should be doing people in AFib. Same thing with bypass grafts. I've always taught at our center that we shouldn't scan people with bypass grafts, but I'm also being schooled by some young cardiologists and radiologists that are showing us now we could do the bypass grafts. So we're moving away from these 2 contraindications that I've always sort of said, bypass patients, let's not do them. AFib patients, let's not do them. We're moving away towards doing them, just reconstructing in AFib the R wave, reconstructing this R wave plus 300 milliseconds or retrospective. Chris, you want to add to that?
Yeah, no, I think absolutely. And, the scanners, the CT scanners are becoming so fast, they're very forgiving. And even in patients with AFib, even though the heart rate is variable, we're still generating motion-free images. So absolutely, I agree with what Mo's saying.
Okay, and also along those lines, we find that some of our patients that we aggressively beta block that then get lower in their rhythm start to throw a PVC or 2. Right. How does that affect you guys as far as image quality goes? For us, I know we try to avoid that, so we may hedge toward a slightly higher heart rate to get a normal, steady sinus rhythm, and avoid trying to drop down into the PVC range where they're throwing funky beats or PACs. How does that affect you guys?
Yeah, no, you're right. PVCs are usually no good. They can affect image quality. One thing that we encourage everyone to do is to, monitor the EKG for a while, for a few minutes prior to scanning, and just observe what's going on. If the patients are throwing multiple PVCs, just picking up the phone, giving us a call is fine. We may modify the protocol and just say, look, given the frequency of these PVCs, let's just do a retrospectively gated exam. And, obviously subject the patient to a little bit higher radiation, but if there's a lower likelihood for for generating, motion-free images, then oftentimes we'll go that route. But the benefit of scanning retrospectively in that scenario is that you can do what's called EKG editing. And so you can go back and actually remove data from the PVC and really clean up the images nicely. And we'll come and show you how to do that if you're not familiar with EKG editing. But that's typically how we handle it. But again, we want to encourage everyone to pick up the phone and give us a call. I mean, that is part of, our service is to communicate with you guys, to really be partners in this. We don't want to operate in silos. We want to make sure that all of us are working together. And so there's going to be scenarios at every site where you'll have a patient and something will be funky. And I think, having us accessible will be really helpful. We can troubleshoot it together and figure out what's the best protocol.
So the question with the ED drugs, then on your protocol, you have 7 days. I know that's kind of probably just, that would be, of course, prime to have them all say, yeah, I haven't taken it in a week. But you are saying, though, if need be, so if I know these are mainly emergency room patients, but like for our outpatients, they come in and they say, well, it was 5 days ago.
Yeah.
I mean,
that's okay.
We're good.
Yeah, as okay. Long as, so again, and we'll probably modify what we have on that poster, but really the rule is 24 hours for Levitra and Viagra, 72 hours for Cialis.
Okay.
Yeah. All right. And again, we can scan patients without nitroglycerin. That's okay. We want to know about it beforehand, so it does really warrant a phone call, because if there's other factors that are going to affect, adversely affect image quality, then we may want to decide not to scan the patient. But usually you can still generate, if you can control everything else, heart rate, breath hold, the patient's cooperative, we can still scan patients without nitroglycerin. We don't encourage that, but it can be done.
While we're rolling these programs out, I'd like we should finish up here so we're sticking on time. I just want everybody to remember why we're doing it. If you remember one thing, remember those Kaplan-Meier curves that Chris showed. Patient survival in every study, 13 randomized controlled trials, is better. People, by offering this to our communities, people live longer with reduced heart attacks and reduced chances of death over 5 years from the scan. So because the scan is so sensitive, it finds much more coronary disease, much more problems that brought people to the hospital in the first place, they live longer. So you are participating in providing better survival for patients through diagnostics. So that's the number one reason I remind people, because change is hard. And and our work is hard. The work we do is important and it's hard. And in diagnostics, it's not always directly clear how you're helping your neighbors when they're showing up in hospitals and emergency departments. Well, this is how you're doing it. By providing all these 1,000 things that we do, by beta blocking people well, to get a good heart rate, to get a diagnostic scan, and then us reading and communicating well, we're improving survival. We're making people live 40% better outcomes than doing stress testing, because stress testing misses so much. So just remember that while we're rolling out new programs and we're having to learn new things, is that you're participating in the practice of medicine at a very high level. I want to be cognizant of everyone's time, and if nobody has any other questions, it's 8:23. We went 6 minutes over what we were scheduled for. If you have any other questions on the email, the poster that we talked about was attached to the email that we sent out. If you didn't see the poster, just ask anybody who got the email and they'll send it to you, and just look it over. It sort of summarizes this stuff. This recording will also come out for anyone that wasn't here, and we will see you back for number 2 next month in 4 weeks.
All right.
Okay?
All right.
One more thing.
Thanks, everyone.
Can you make that PowerPoint available to us?
Absolutely. Yeah, I can. I'll distribute it by email.
Thank you.
Mm-hmm.
Okay, everybody.
All right.
Have a good day.
Take care.
Okay.
Did you get the